Welcome to the Rural American Surgeon. I'm your host, Dr. Randy Lehman. On this show, you'll receive powerful insights and resources for rural surgeons. I'm a general surgeon in Northwest Indiana, and this show is tailored around the nuts and bolts of rural general surgery practice. But you'll find topics ranging from practical surgical tips to a host of others, including rural lifestyle, finance, training, practice models, and more. We'll have a segment called Classic Rural Surgery Stories, where you'll get a feel for how practice in the country differs from the city. Whether you're a surgeon, other specialist, or primary care, or simply someone interested in healthcare for rural America, I'm glad you're here. Now let's get into the show. Hello, listener. Welcome back to the Rural American Surgeon. We're here joined today with Mike Sarap, rural surgeon from Southern Ohio. And we are so privileged to have you here. You have such a rich and storied history. First off, you went to the same medical school that I did, which is University of Cincinnati. But the difference is you graduated before I was born. And so you've had a 35-year or more career. And I was reading through some of the things that you've been able to do and just the whole body of work that you've been able to publish as a rural surgeon, have a busy practice, be very involved with the American College of Surgeons, and you've been able to be involved in some leadership opportunities there. We'd love to talk about that a little bit more. But just want to say thank you so much for joining us. Welcome to the show, Mike. Appreciate you being here.
Totally my pleasure. Thanks for having me.
Absolutely. So why don't we dive right into the rewards and challenges of rural surgery practice? You've been a rural surgeon your entire career, correct?
Yes.
And this is by choice.
Yeah, sure.
And so what have been some of those things that have kept you going for this long, and what you're most excited about with your job day to day?
I think that the reward is certainly when I started out, it allowed me to do everything in my practice that I was trained to do. We were trained in the day where everything was open, that general surgeons did all the vascular and a lot of thoracic and endocrine, those kinds of things. And so when I was looking for a place to practice, I wanted to be able to use those skills to help people. And so it was very rewarding to have a broad-based practice. I had a really nice training experience in endoscopy, and that's been a big focus of my practice as well, advanced endoscopy, as it is with most rural surgeons. I think that one of the rewards is that you really can make a difference. You really are meaningful to people. It's not like you're in a major metropolitan area and there are 15 or 20 general surgeons and everybody does a good job and everybody helps people. But in a small community, you're really filling a need. And I got very excited about that. And throughout my 37 years, whenever we felt that there was a need, a gap, we've been able to go and fill that with extra training, extra procedures, more technology. I think that's very exciting in terms of rewards. The long-term relationships, we've had 3 different cancers that we've taken care of. People have taken care of them and their kids and their grandkids. So similar rewards everybody that works in a small town gets.
How many of your patients do you know, like you grew up in Ohio, so you said you're practicing about an hour and a half from your hometown. Is that correct? Do you see people that you knew like from high school days?
Actually, I do. Yeah. I see some folks that I graduated with that actually grew up on my street that just happened to migrate towards this little town as well. We had people that came here to teach or to coach. And I've taken care of my high school football coaches. I've taken care of people who lived on my street. And certainly through the years, I've taken care of my kids' teachers and you name it, quite a bit of relationships. There's all these little ties and connections in a small town. It's never just about a patient physician. It's always that, you were in Cub Scouts with my kid or you went to school with my kid. So a lot of personal ties.
Yeah, I basically start every conversation with, let's find our 1 degree of separation. It's not 7 degrees. But see, my whole thing was I wanted to come back to my hometown too. So it's very personal for me. And I know everybody. I mean, it's crazy. And of course, the next town over and then the next town to the south is where my mom's from. My dad grew up. So if I don't know them, they knew my parents. So you can't hide either. That's the other thing.
Yeah.
And then it's pros and cons. But so I'm 4.5 years out. All right. And I started at one critical access hospital with the goal of going to my hometown, which is the next county over. And I was able to do that. It's a long story, not for right now. I've talked about it in some other podcasts. But now I'm in both, and I actually have two other critical access hospitals in adjacent counties that I sort of do 2 days a month, sort of outreach thing to right now. So I've built practice. I do kind of know what it takes, but I'm still sort of early on. Talk to me or to that chief resident that's considering going out to rural surgery. How do you build a practice in rural surgery?
Yeah, I interestingly wrote a little piece about this. The College of Surgeons has sort of a primer or workbook for employed and self-employed surgeons. And so I wrote a little piece on this, but I think that the three big things are touching base with your community, with your colleagues, and with your co-workers. And there's several ways you can do that. I mean, I think you're the expert in your little town about medical problems, particularly surgical problems. And so to build a practice, you can get out there on the radio, the internet, give community presentations, those kinds of things. There are things that are nationwide that you can be the champion. Stop the Bleed is an amazing program. I don't know if you're familiar with that, but you can start with your local EMS and take it to the schools, the churches, and you can be a local champion. And once you train a few, then they become trainers, and it's like spreads like wildfire, but your name is on that. I get into the schools a lot. I go to college days. We have a program that we work with the Scouts called Medical Explorers, and the hospital hosted over several weeks one night. And one night they would come in and we would mock up a laparoscopic trainer, would have little foam organs and have the kids help each other do a gallbladder or take out a uterus laparoscopically. You know, they couldn't see what they were doing, and they got the real chance to see on the screen what it looks like. And at the same time, we had an innovation head, and so the anesthesia's there letting the kids do an innovation with a glide scope so they could see what they were talking about. And so another night, the orthopedist would come. But that really spreads the word in the community that you care about the youth and that you're involved. And a lot of times what happens is the parents come to these things and they want to kind of play games with it too. So you can do that. You can do free screenings in the community. We do skin screening several times a year. People are walking around. I know you see the same thing. They don't have insurance and they're walking around with these horrible lesions. And we see them and we can get them in the clinic and get it taken care of for them. We've done vascular screenings. We do free colonoscopies if they meet a need. All kinds of things in the community that you can do. And you can get on social media. The local radio and TV stations are always looking to fill time. And you are the local expert. So that can really, really build something. And then once you show this commitment and you meet people, you can join Kiwanis or Rotary or something like that and meet people. If there's a need in town, you can be part of a cooperative effort to meet that need. I think those are ways that you can endear yourself to the community, as well as just showing up and taking care of people when they come in sick in the emergency room or injured.
Yeah, that's obviously step one is, the meeting people at their point of need. And so who is your client, if you will? So let me back up a second. What is your model like? Your practice model? Are you employed? You're independent, and has it changed over time?
Interesting time to bring it up. For 37 years, I've been in a 3-person private practice. We have been our own bosses for 37 years. We have an office right across the street from the hospital. We only take call in one hospital. My 2 younger partners actually did some locums work on their days off in the next county, taking call and doing elective work. But we're in one of the most socioeconomically disadvantaged counties in Ohio. We're talking in terms of our payers, it's 85% Medicare and Medicaid. And it's become very difficult to make a living that way. And we were in the process of hiring a brand new partner, which brings us to 4, which makes me very happy. And this is a person that I've been mentoring for 18 years. She's a local woman and a very gifted surgeon. And I didn't feel like we could offer her what she needed to have and continue to make my partners happy. And so as of August, we joined the largest group in Columbus called Ohio Health. And they actually, our hospital joined their group about a year ago or a year and a half ago. And so they now own the hospital, and I'm working for the man, I guess, if you will, for the first time. So I've never had to deal with RVUs, and basically we just worked hard and did in-office billing, and now things have changed a little bit. And I think it's very difficult to run a private practice in an Appalachian county like we are, where the reimbursement is so low, continues to go down. And I have my employees who I care about very much are worried about paying for childcare, and medical, the expense of health insurance goes up all the time, and yet we get cut 3% every year. And so it just came to a head. We lost a couple of key people in our office in terms of a coder biller and some other people. And so several things came together at once, and we felt like it was a great opportunity to become employed so that I could guarantee that my partners are going to have the best situation going forward. And we got a brand new office building out of that, and we've got a brand new state-of-the-art Epic EMR in my office, and we were paper before, if you can imagine that. So it's been an interesting couple of months changing over from paper to EMR. So I think for the long run, it's going to be good for my partners, which I care about. I'm sort of on the end of my career, and I can tolerate pretty much of anything. But I built this legacy that I want to continue to see improve and continue to provide care for my community, which after 37 years, this is my hometown now, it seems like.
Yeah, I can imagine. You've just put so much into it. I think your story is going to be very familiar to some listeners. The interesting part is that I just did the same thing within a 4-year span. I don't know if are you aware of much about what I did here?
No.
Started independent practice. Okay. Yeah. So, well, I think you're about 10, 15 years behind most people in terms of selling to the hospital or someone, because it's been pushing so hard, and you're in a very difficult place. So that shows, like, first off, the level of volume that you've probably been cranking out this whole time to hang on, and then secondly, just the willingness, and the commitment. Because what I did is, first off, I took an employed job where I had loan repayment and I was a W-2 employee and everything. Now I go to get my loans paid off. And then I wanted to go independent in my hometown. But the problem was I was about 25 years too late. Yes. So I started, do you know any of the numbers, like what you were being paid dollar per RVU on average with your practice before you joined the hospital?
Not a clue. I mean, I didn't know what an RVU was.
Yeah. So you tracked things in terms of dollars, I guess, of collections and billing, and then also volumes, numbers of cases and things like that, how many patients you saw per day. And so,
right.
So when you were setting up this new contract with the hospital, what pieces of information did you have to go get in order to know that you were getting a fair shake for you and your partners?
Well, I mean, I know what we've made over the last few years, and it's continued to go down in terms of the salary that we're paying ourselves. I know what our expenses have been. And so, number one, I could just compare the base salary. And then they offered a productivity bonus as well and some other incentives. We run a wound clinic for the hospital as well. And so our volume is, and like many rural surgeons, we have a huge endoscopy volume. I do 1,200 endoscopies a year. Wow. I have about a 5-county referral area that I've been doing screening colonoscopies for 30 years. And so I know kind of what volume of procedures that I do. And if you start counting colonoscopies and gallbladder and hernia, you can just scratch in your head RVUs, how many you do in a year, and compare that to what they're asking for the base salary and compare that to the productivity. And we have a pretty good idea what we're looking at going forward if they are able to capture all of our activity. We've done our own billing and coding in-house, and it worries me that somebody in Columbus is going to be gathering my charts and trying to figure out what the coding and billing is. But I think that they've offered a very good deal. I think that they are negotiated, with good faith that we're the only game in town. They want to continue to have a successful rural hospital in their system, and they actually have 8 of them now. They've gone on a spree where they feel like that the metropolitan covered lives are very difficult to access now, and their intent is to go out into the country, if you will, and spread their influence. And so they want to have a successful small hospital here, and they know that general surgery is a very important part of that.
Yeah. Well, it sounds good.
Yeah. I think it's a good deal, and my partners do, and I think we can worry less about human resources and hiring and firing people, and scratching out, making sure that my employees can pay their child, their babysitter and things like that, and just come to work.
It's so hard. So basically what I did is I started an independent practice while I was employed with the permission of my employer, and I was the next county over. I'm like, it's not a competition here. They're 2 separate markets. People that are leaving town aren't leaving town to go to the other small town. They're going to the city up and down the interstate. So anyway, it all worked out. And I said, if anything, it's going to increase your volumes. And it did, because my larger cases I took over there because I was more comfortable. So anyway, I built essentially $600,000 overhead, for a part-time surgeon. I did have a nurse practitioner working for me, but I wasn't part of that overhead, and I didn't pay myself anything for like 2 years. And I lost like $20,000-$30,000 a month for like 18 months to 2 years. And then, it's not sustainable. And
Exactly.
what I didn't know is, so I was getting paid $57 per RVU on average from insurance. And I was getting paid more than that from my employer with benefits and no cost to produce that.
Right.
So no overhead and getting paid. It was a tiered structure at that time, 75, 85, 90, based on a productivity thing. But then I had a base salary guarantee underneath that. And the base salary guarantee, I guess technically if you calculate it out to get into the bonus, was like 108, So that's not a lot. You can't get that, total, but when you factor in, the call and the base and everything, that's truly what it was. And that was a guarantee. So I had no idea. The problem is I didn't even think to call the insurances and ask. I didn't know where to start in terms of like how much would I actually get paid for the things that I was doing.
Right.
And I had an app on my phone that kind of showed me what Medicare would pay, and I almost couldn't believe it. Yeah. And so I truly didn't believe it. I'm like, that can't be true, because how could you ever have a practice? Well, stupid me. I still started the thing. I had to go through this. It was just part of the journey. Yeah. And anyway, long story short, I contracted my business to the hospital. And so now I'm like a 1099, but I still have the business. That's the Liberty Clinic thing that you see behind here.
Gotcha. Yeah.
So in terms of growing the practice, where I was initially going to ask is, who's your actual client? Who are you actually working for? Because now I have this 1099 practice, and then I was able to set up the same model in a good, successful way with 2 other adjacent critical access hospitals, because I know it's not adding. I'm only going to basically get paid for showing up. And then the hospital and I have a shared interest in being busy, because we set it up with a daily rate. So I get protected for showing up, but then I have an RVU calculated daily. And so if I have a big day, I'm happy, and patient's obviously getting care. The hospital's happy. If I have a small day, I'm protected. And I don't really want to have small days because I get after it, So the hospital's incentivized to keep it going. It's been working out pretty well. That's all. The 2 hospitals I added are just this year, so I need a little bit of time, to see how it all works out long term. But I got thinking about it, and I'm like, who am I really working for? Like, I'm working for the patient. That's what I tell all the patients, and they are my client, right? And I have the professional relationship with them. But 80% of my patients come from primary care providers. And so really, I'm kind of working for them too, because if I'm not taking care of my referring source, then I got no business. I have no practice basically. And then now I'm contracted with the hospitals and they're my employer, and I have, so in a way, they're my client too. And it's sort of like you need to think that all three of those things are true and maintain and develop each one of those relationships in different ways. But have you ever thought of it like that at all?
Well, you wear a lot of hats, we all do. But when we're in the room with the patient, they're our focus.
Right.
That's the bottom line, is that we're there to care for them. And yeah, like I say, I joke now that I'm working for the man I never did before, but that comes with a whole lot less worry.
But even before, it's like, am I working for Anthem though?
Yeah, I get
to
it.
have a contract with Anthem, and
Yeah.
that'll take care of their patients and stuff. Now, Anthem never really put any patients
80 or 85% Medicare, Medicaid, you're working for the government, basically.
Right.
And, you really can't negotiate with Medicare or Medicaid what you're getting paid. Just you become on a treadmill and just keep going and going. And, at some point in time, the treadmill has to break down.
Right. Your new partner, is she bringing anything to the practice that you guys are not currently doing?
Absolutely. She's bringing robotics. And so my most recent partner before her is 11 years out. And basically, they were beginning to dabble in that, but he's fully laparoscopic trained. But she's going to bring robotic. We pushed hard for the hospital to bring on the robot. And that will help us to recruit for OB-GYN in the future and more general surgeons when I need replaced, which will be pretty quickly. And so that, plus she's going to do complex abdominal hernia component separation repair. I really have not embraced that. We do laparoscopic hernias, but we haven't really learned component separation. And I don't feel comfortable doing that on my patient by looking at a YouTube video. I really don't. I've embraced lots of new technology, the RCPs and the other things that we'll talk about today. But I feel confident doing those, and I want to do the right for my patient. So, yeah, she's going to bring robotics and complex hernia repair and some other things that she's picked up along the line. And we're going to teach her some things, a lot of things. And I've done that with each new partner.
So what sort of things? Are there subspecialty things outside of normal general surgery, or what sort of things are you going to be teaching her?
Well, we have a pretty advanced endoscopic practice. We do ERCP, obviously. We do stents, esophageal stents. We have a capsule endoscopy system. We do pH and manometry, and we do a lot of foregut surgery. And so I showed her how to read a pill cam the other day. We are breaking her in to do ERCPs as well. And that's kind of little baby steps at a time. But I think mentoring and progressive learning is a good way to learn something. You don't have to go off and do a year of fellowship to learn one procedure, especially after you become very familiar with flexible endoscopy in other ways. She didn't do a whole lot of foregut, so we're going to be doing some fundoplications and hiatal hernia with her. And yeah, just a little bit of everything. I mean, we do carpal tunnels and hydroceles, and I still do some open inguinal hernias, and she didn't get a lot of experience with. So it's just kind of day-to-day stuff that they pick up. That one of my previous partners had never put a suprapubic catheter in, and his first colon resection, they couldn't get a Foley in. And he's just dumbfounded. I'm saying, well, here's how you do this kind of thing. So it's kind of learn on the job kind of a thing.
Yeah, I haven't done a suprapubic too either, but it's, very good. So this is beautiful. How big is the town that you're in?
It's 14,000, 40 in the county. And there are literally 8 counties in southeastern Ohio that don't have a healthcare facility. Not all those come to us, but we were right in the middle of where Route 70 and 77 crisscross. It's actually geographically the biggest interstate connector in the country. And so people come from a fairly long distance away. 2 other counties that border us have critical access hospitals and do not have surgical coverage on many weekends. And so it's a broad area. I bet our catchment area is probably over 120,000, 150,000 people.
Yeah. Do you have OB/GYN services there then?
We do. We have 2 very excellent ones, and they have locums that cover them every third. When I came to town, interesting, one of my partner had a very busy OB practice, C-sections, vaginal deliveries as a general surgeon.
Huh.
They were both doing trauma, orthopedic stuff, hip fractures, and things like that. But after I came, we recruited two well-trained OB-GYNs, and they're recruiting for a third. We're very blessed by that. So I don't have to do any C-sections. I'll scrub in and help them if they need something urgent. But when I came to town, we were doing a ton of hysterectomies. I still have full privileges to do that. Certainly, I don't have any problem with adnexal issues in the middle of the night.
Sure.
We have been with and without urology from time to time. We have one that's very busy right now. And so we've done a bunch of those kinds of things as well in the past. Carpal tunnels and a lot of hand stuff as well.
Yeah, it's similar. And the beautiful part of what I have going on is there's four critical access hospitals. They all have different things. Some places they have like 3 urologists come to the critical access hospital in my hometown, and all the other ones have no urologist. So, the phimosis came to me,
exactly.
the vasectomies, and most of the rest of it is just, I thought maybe I would manage a testicular mass when I was in residency, but I don't know. I don't really see the volume, and I don't think I'm in my location. It just depends where you're at. I have, within an hour urologist. So for most of those things, sure. If I really found myself in the opportunity to manage a torsion or something like that, I probably would, but other than that, that's kind of the extent of the urology bit. I guess besides putting up my own ureteral stents for like, if I anticipate difficult colon resection or whatever, I'm pretty comfortable doing that. So that's beautiful. And so why, I guess I can see now why rural surgery is very important to you. I mean, you've lived it, but why did you choose it in the first place? And was there something special, or just why did you choose it in the first place?
I think I came from a small town called Steubenville down on the river, Milltown. I didn't want to go to a big city. I wanted to go to a small community somewhere. I didn't know that would end up being in a rural farming community. This where I am in Cambridge. When I was looking, my parents were still in Steubenville. I had a brother and sister in Columbus. This is kind of equidistant, right in the middle of the state. And there was a real need where I came. Nobody was doing vascular. And so up until COVID, I did carotids and open aortas and distal bypasses. And so there was a need there. There was a need for endoscopy. And so there was a big gap that I felt like I could fill there. A lot of my patients, I was in Huntington, West Virginia, and Marshall for my residency. And rural people appreciate what you do for them. They really do. And I guess you got a love for the common person, mechanics and farmers and things like that. And they come in and they have real problems. They need to get back on their feet, need to get to work. And these are people that run our country. I mean, they're farmers and miners and truckers. And I really felt an obligation to help that part of the population. And, there's 60 million people in rural America, and only 10% of the rural, or 10% of general surgeons are taking care of them. And obviously I haven't changed in 37 years. It's the same rural community. And so I must have found something that I like. I think the other nice thing is that you can have a real family life. You don't take call in the hospital. If it's a small town, then the local soccer field or the football field or the gym where there's a wrestling match is literally 3 blocks from the hospital. So I can take call and I can still see my kids' activities and now my grandkids. The soccer fields are a mile away. And that's been really good for my family life. I really think that it's a good mix back and forth. You're not stuck in the hospital taking call. So I love that part of it as well.
I would echo that. Not to mention the rural hospitals let you land your helicopter on site. So that's nice. They don't let you do that in the city either.
Yeah.
Big plus. So let's move on to the next section of the show called How I Do It. This is my favorite part of the show because I like to talk about surgery, and I could do so all day. You're going to talk about something that believe it or not, I'm equally as passionate as you are about this very niche thing.
Yeah.
I am a big supporter of laparoscopic common bile duct exploration in the rural surgeon's hands. I mean, in the urban surgeon's hands, it could be a great trick too, but it's just that you have ubiquitous ERCP availability in the rural hospitals. And often when I trained at Mayo in the ivory tower, the question was not, can we get the ERCP? It's, can we do the ERCP and keep the patient asleep as we transport them from endoscopy and do the lap chole that same exact moment? And I just wanted to say one more thing about the family life thing. Come here, buddy. Jack, come here. Yeah. Now I'm in my own private office, and you had that, throughout the years. So that's a little different, but still, when I'm in the hospital and my kids can, come, they keep books and toys and stuff in my office, even in the hospital. But if, at Mayo Clinic, it wasn't the same there, for example, and it's a little bit more difficult. Jack, you want to say hi too? No, he doesn't want to. He's fine.
That's great.
But yeah, having the kids around. And then I had one more thing. Can you get a mailer?
Oh.
Please. One of the things that we mailed out when I first started my practice. So when I first came to town, before we get back into the lap common bile duct exploration thing. So I have these mailers made. And this was a big project. Probably part of the reason I lost so much money, but that's okay. Totally worth it. So I don't know if you can see that.
I see it. Yeah, that's cool.
If you need whatever kind of surgery, come on, focus, buddy. There. If you need lipoma surgery or varicose vein surgery, what's this one? Debridement surgery. This is for wounds. Get to the good stuff, man. There we go. Hernia surgery. If you need hernia surgery in 30 years, call us. But if you have an abdominal bulge today, call my dad. He's the best.
That's fantastic.
More information like on the inside about the, thing. Maybe I can put a link up in the show notes about this, where I ordered it and everything. If there's anybody that's actually in private practice that has an interest in putting something out, I think we produced this thing for $1.50 a piece. Yeah. And then we mailed out 40,000 of them.
Wow.
Yeah. Good. And I got a lot of people that responded just initially to the mailer. But more importantly, like now, 2 years later, when their primary care doctor sends them over for something, then they're like, yeah, I remember I got your mail. It's like, and I'd only had to do that once,
Yeah.
I haven't pulled a lot of print ads or anything. I do have a Facebook page, and you didn't mention that earlier, where I do Facebook Lives and interact and just give as much free content as possible. I feel like that really helps. The point of this podcast is not for my hometown, right? This is the national body of rural surgeons speaking to a rural surgeon, totally different. But you still can use that live in video, just interacting with people. It's wonderful. So thanks, guys. They're going to go home. So
that's terrific.
I'll see you later.
Thanks.
Love you.
Thanks for sharing.
Yeah. So Brittany wants to say hi.
Hey.
Come on, come in. Okay, fine. She doesn't want to. They'll cut it out. Yeah, you can have it, buddy.
Yay.
Okay. So back to laparoscopic common bile duct exploration. Tell me, I guess, first off, the patient that you would consider planning to do this on.
Well, I mean, potentially it's anybody I do a gallbladder on, but it could be somebody that has elevated liver enzymes. Potentially somebody's ordered an MRCP. It's got some defects or sludge on the common duct. It could be any number of people that we would plan the procedure. We really don't have to plan it. It takes 2 minutes to open the equipment. All my staff is already trained, and we have fluoroscopy in the room because we do cholangiogram on everybody. But my thinking for this, and I've been doing these for 12 years, and my thinking on this is I trained doing open cholecystectomy. We did not do any laparoscopic cholecystectomy by training. And so I had to learn that on the job after I got hired. And the other thing is we were doing common ducts, open common ducts very frequently in training. And so it was secondhand. But when this laparoscopic cholecystectomy came around, I said, geez, how are we going to get to this common duct now if we're not opening the patient? if we see common duct stones, what are we going to do to fix that? So the first thing I went and said, we need to learn ERCP. And so I was hiring somebody at the time from my program, and it just so happened my program had a surgeon that did ERCPs. And I told this guy, you got to go learn that before you come with me, because I want you to teach me that. There was actually a course in the Inner Harbor of Baltimore where they had live animals. They had either pigs or dogs and live ones. And basically, you turn left instead of turn right to find the ampulla. And it was like a human ERCP. So I went and did the course and then got mentored by my guy. And so we ended up doing ERCPs. And then I figured out that, well, maybe we could get into this duct laparoscopically. And I started doing these 12 years ago myself. And we have developed it and got a little bit better at it. And so we have 150 cases now between me, one of my younger partners that came on who was interested in learning it. And so we've got it down to a pretty good refined skill. And, if you don't do it, you ship people out. Most people don't have the ERCP in a small town. It's an extra procedure, more cost, longer length of stay. And I think the most important thing is for a rural surgeon is when you send somebody out, it's because you've done an incomplete operation and the community says, well, this is a simple gallbladder. Why do I have to go to the big city? Because something you couldn't do for this gallbladder. It's subtle and it's a little hazy, but I think that's a really important part. If somebody comes to you with a problem, we ought to be able to fix that definitively and not have to send them out for every little thing. And so I think that's almost as important as all the financial cost savings and all that. So, yeah, I've been a proponent of that. And academics keep pushing back everywhere we go. And the residents are dying for me to convince their staff to show them how to do this. But they want to think it takes too long and it's a hassle. And why should they do this? And it's not. It's a fairly straightforward, simple procedure.
I remember being in residency. I mean, in Rochester, we did not do cholangiograms on almost anybody, and when we did, it was this big ordeal. And I do them routinely. I did one this morning. It added less than 60 seconds to the procedure. Normal cholangiogram. It's maybe hard for somebody to believe that doesn't live that, but that's the truth. The whole gall, I don't know what the time was, maybe 25 minutes or something for the whole case, and probably 1 minute spent doing the cholangiogram. And
yeah, agreed. And the other thing is if people end up with common duct stones or pancreatitis or jaundice 5 weeks after you do an operation on them for a gallbladder, they're asking, well, why didn't you find that? It's embarrassing. It really is. And it decreases your respect and your reputation in town when you have people bounce back when it's something that should have been found on the first. It's like 1 out of 9 cases that people have common duct stones. It's not unusual or rare. And so if you look for them, you're going to find them and be able to fix them.
Yeah. So that's why I specifically asked earlier, like, who do you go planning to do it on versus how often are you doing it sort of unknown? So for me, the only thing that you didn't mention was a dilated common bile duct. So you said having stones or sludge in the bile duct for sure, but sometimes it's just an ultrasound or a CT scan and they didn't have an MRCP, but the bile duct is dilated. So that would be another reason. And then I wanted to ask you, how do you think about direct versus indirect bilirubin? Could you explain that on like a med student resident level for me?
Oh, I just look at the total, and if it's elevated, I think more importantly, I like looking at the alk phos because I got a lot of people with fatty liver. I'm sure you do. Middle America, everybody's got obesity and everybody's got fatty liver, and so the parenchymal enzymes are up fairly frequently.
Yeah.
But if the alk phos, that's more of an obstructive thing, and if they have an elevated alk phos and just a total. Doesn't matter what the fractionation is. I worry that, and I talk to them about the fact that there's possible common duct stones.
So let me share, if there is a med student or resident listening, what I was trained, believe it's true, about, hope I'm not sharing a black pearl, about direct and indirect bilirubin. So, direct bilirubin is directly conjugated, if you will. So it's already past the liver. So indirect bilirubin is before the liver. So if the indirect bilirubin is elevated, there's a liver problem, like, for example, cirrhosis. But if the direct bilirubin is elevated, usually it's a post-hepatic problem, like a bile duct problem, such as obstruction. And so nobody ever gets the direct fraction either around me. And I'm thinking, am I crazy or is everybody else? But I always get the direct fraction. And if you have just an elevated indirect bilirubin, and especially if it's mild, that's normally Gilbert's syndrome. But if you have an elevated direct fraction, that's more suggestive of a post-hepatic, like bile duct problem. So like a classic person that I would take for a laparoscopic common bile duct exploration on and plan for it would be, they've got a dilated bile duct. So normal is less than 6 millimeters. Maybe this person has a 1.2 centimeter bile duct. Ideally, they have a filling defect in their distal bile duct, either on CT, ultrasound, or MRCP. Even if they don't, their alk phos may be a little bit elevated. Their direct bilirubin is elevated. Maybe their indirect is elevated a little bit, but they have a direct bilirubin elevation. Ideally, they don't have a lipase elevation, but sometimes these people can get biliary pancreatitis as well. And the fact that you have stones in the gallbladder, is suggestive of the whole process. But what kind of stones they are, everybody knows that you can have one big gallstone that takes up the entire gallbladder. That's obviously never going to give you a choledocholithiasis, stone in the bile duct. That might give you bile duct problems like a Moritzi syndrome, because that stone might push up against the common hepatic duct proximally. But those little stones that are like shot, BB shot, those are the ones that'll spit out. And then lastly, probably most importantly, is the anatomy of the cystic duct. That's probably the most important thing for me to decide to take somebody for laparoscopic common bile duct exploration. So if they have a short, fat cystic duct, that means I'm going to have an easy time with the lap common bile duct exploration. If they have a long, skinny duct, first off, they're less likely to actually have choledocholithiasis because their duct prevented the stone from passing in the first place, but maybe they do. But in those people, I will sometimes selectively still do the ERCP up front, sort of a discretion thing. When I was training, the surgeons I was working with, they were about a 45-minute drive from Rochester, where I learned how to do this technique. And they said, we're kind of tracking our outcomes. If we feel like we can clear the duct, a certain percentage of the time that we're happy with, they used 80% just as a number, then we think we're using good judgment, sort of like the negative API rate that we used to think about. Because if you're not clearing it very much, then maybe you're choosing some of the poor anatomy. Maybe you don't have good enough technique, I guess, but they felt like mostly it was the choice of that cystic duct anatomy that determined if they were going to be successful or not in their experience. And so I said that back at the big house at M&M conference, and I got pushed on that by one of our, kind of our main HPB surgeon. And he said, I disagree. I think that if you were successful 20% of the time, like, who's to draw that line? Because that person still didn't have to go for a double procedure. The risk of pancreatitis, also the transport and the cost and all the things. Oh, yeah. So that being said, I've done it about 2 to 3 times a year since I've been out. I've been out 4.5 years. And I've had one that I haven't been able to get. So I feel very comfortable with my numbers too. And I think the main thing is having that persistence, because there were a couple I didn't think I was going to clear it, but I just kept slowly working on it and then did eventually clear it. So tell me, you're set up for a lap chole. Let's paint another scenario. Let's say that you did a routine cholangiogram and you found an unexpected stone, and then walk me through the next step. So when you're doing your lap chole, 3 ports in the sub.
Yeah.
Okay. So you got 3 ports, and then you have where do you take the gallbladder out? You take it out of the
umbilical. I do a 10 at the umbilical area.
Okay. So that's my setup too. So say you're set up like that, you find a stone, then what are your next steps?
I'll tell them to open the kit. And the kit is a introducer that's stiff, 4 millimeters external diameter. We use a TAUT, T-A-U-T, introducer, it's called. And it's got a little trocar on it. So we make a poke hole for that and put that in separately. but I tap it out and look at the angle of where that introducer. I want that introducer to come right down to my cystic duct. And it needs to be stiff and it needs to be long enough to get to the cystic duct. So that's number one. We have a guide wire and a biliary catheter. And when I started doing these, TAUT made an entire kit, introducer, guide wire, and biliary catheter, and then they discontinued it. And Cook makes a nice biliary catheter, balloon catheter. You can use any old guide wire you want. And then that was on back order, and there's another company that you can get as well. So there are 3 or 4 companies you can get a biliary catheter. But in a pinch, during COVID, when none of that was available, we're using angioplasty catheters. You can just go get an angioplasty catheter. The balloon is 8 millimeters in diameter. I think it's 20 millimeters long. And you can use a vascular angioplasty catheter if you need to. But you have to have a longer guide wire for the angioplasty catheter.
Question about that. So when you say just go get, do you mean just go get from a supplier, or do you guys actually have an angio catheter?
Yeah, we had angioplasty catheters when we were doing vascular.
Gotcha. So we don't have those, in our,
you can order them. You can order 2 or 3 of them and have those if you can't. But the biliary catheter is better because it's shorter and you're not dealing with a whole long wire, and it's just long enough to get it across the ampulla. So, it's a very easy package. It's all in one little kit. So it's introducer, guide wire, and biliary catheter. We clip the cystic duct, common duct junction. We do a cystotomy. I usually do my cholangiogram with a Kumar clamp. We don't usually open the cystic duct. We clamp the gallbladder cystic duct junction. I poke it with a needle. Very quick, very easy, and you don't have to open and thread something into the cystic. So when we find the stone, we pull that clamp out, we put a clip above, and we open the cystic duct. And the key is that if that introducer is stiff enough, you never have to grab the guide wire or the biliary catheter with a manipulator. Never. You don't touch it. You put that taut introducer right next to the cystotomy site, and you can thread your catheter right down the cystic duct. If you introduce the tip of the catheter into the cystic duct, then you can thread your guide wire. Obviously, fluoroscopy is already there because I do a cholangiogram on every patient. And so they just move it in, you move the guide wire down, you situate the 2 marks on the biliary catheter balloon across the ampulla. I blow it up by hand with air. I don't use any kind of fancy insufflator or saline in that. I blow it up for about 30 seconds. I pull the balloon back to the cystic duct, common duct junction, pull the guide wire out. I actually blow the balloon up again and put dye through there, and I can beautifully fill that distal common duct. And if there's any sludge left or anything, the fact that the balloon is up proximally helps you put forcible pressure and you can flush anything out. But if you have a clean common duct distally, then you can put the balloon down and put more contrast to make sure that it didn't go above. You didn't flush that stone above. And you're done. You pull things out, you clip the cystic duct. If it's a good clip on it and you're comfortable with that, you don't have to put a Jackson Pratt drain. When we first started doing these, we said, we're manipulating the duct. We used to put a drain in everybody to make sure they didn't get a bile duct leak. We don't do that very often as long as it's a secure cystic duct closure. We did 150 cases. We looked at it. Our median time for surgery for gallbladder cholangiogram was 40 minutes. And our median time was about 55 to 60 minutes if you add the common duct exploration. So it took 10 to 25 minutes to do this. We only used the choledocoscope on 1 out of every 10 cases. We do the balloon and the guide wire, and that is it on the majority of the cases. If there's a big stone or it's not wanting to flush, then we'll put the choledocoscope down, grab it, and push it in. We rarely pull things back. We usually just push them into the duodenum to get rid of them, because that cystic duct sometimes is quite small. You don't want to tear that. On occasion, because we also do ERCPs, you can do crazy things. So we used a lithotripsy. It's an old metal big thing. You can thread it down the cystic duct, and you can crush that stone from above. Where this is a tool that we use at ERCP. Make the stone smaller, fractionated, then flush it out with your balloon. So once you get good at it, you can start using different techniques and instruments. But the vast majority of the time, we cannulated 97% of the time, cannulated the duct. And on the first 5 years we looked at, we were 82% successful in clearing the duct. And all the ones that we couldn't clear, we just turned them over and did an ERCP and got it out that way. Or if endo was busy, we did it the next day. I just did one yesterday. We did a cholangiogram, and the whole duct was full of sludge and stones well above the cystic duct junction. Not a good candidate to do the laparoscopic. And so we did the gallbladder, finished that, called the endoscopy tech in and turned them prone and did the ERCP. And it was literally full. We just kept pulling more and more stuff out after we did a sphincterotomy. So that's kind of it in a nutshell. We've not had any episodes of pancreatitis. It's a very small, that 8 millimeter dilating balloon, you're rarely going to get bleeding or any kind of complications. We did open common ducts, and we used those Bakes dilators, and those are a lot bigger than an 8 millimeter balloon. And we're not manipulating the pancreas duct like you do from ERCP below, so the chance of pancreatitis is pretty low.
Sure. When you first started this, though, you did not come into training, out of training doing it, and obviously didn't do laparoscopic surgery. Did you do any course about laparoscopic common bile duct exploration, or do you have any recommendation for a course if somebody was trying to add this to their practice?
No, there was no course when I started doing it, and it was 2012. But I read about it. I read that some people were, thinking about that. Subsequently, now at the College of Surgeons, they have the Rural Council, Surgery Council, puts on a skills course every year. That part of it is ultrasound and things. But they've got a pretty good trainer. The folks from Northwestern now has a pretty good trainer that you can go and kind of learn how to do these things. They do it a little different than I do it, but there are trainers out there. And every year, if you go to the clinical congress, you can take a course on this. And there's untold numbers of videos and things like that.
Right.
But we just kind of, started on our own, and I got a biliary catheter and gave it a shot.
What choledocoscope do you use?
We use let me look here so I don't mess up, Boston Scientific Spyglass.
Yeah.
We had a flexible choledocoscope. It was reusable and was horrible. The optics on it were absolutely terrible. Every time we used it, it would crack a fiber, and it really didn't work very well. And these disposable ones, they're very expensive, so we don't use them unless we need them. Some people have the feeling that, oh God, you're using that scope on every common duct exploration. We're not. But the optics are incredible. I mean, you can see all the way up and down that duct, and you can see when you pop into the duodenum, and it's just a whole nother ballgame when you do that. It really is very helpful.
So when you place that scope, does it go through your introducer?
It doesn't go through the taut introducer. It can go through one of your 5 millimeter ports, or it can go through the white Cook introducer that comes with their biliary kit. It fits very snugly. There's not an air leak, and it works better. If you try to squeeze that through something, then it might break it. But the Cook introducer, which is white, I don't know the exact size of it, but it works great. It seals, and that's what we use. We just exchange that the thick black, the small black stiff one, for the little bigger size right through the same hole. And a lot of times we use the guide wire for the scope too. There's a guide wire.
And it's 035 guide.
What's that? Yeah, 035 guide wire. And if it's a tortuous cystic duct that you're having a hard time threading the scope, because the scope's bigger, again, we do the same thing. Put that introducer right into the cystotomy site and then put the scope down. But if your guide wire goes, the scope will follow it.
How far down do you dissect? You're saying cystotomy site. I do a traditional cholangiogram I use the taut catheter, so I clip and then cut, put the catheter. How far down on the cystic duct do you dissect?
Not very far. I mean, it's just a little bit below the cystic duct, common duct junction. The further I stay away from the common duct, the happier I am. So we don't dissect that far down at all. We just get it so that we can get around it, be comfortable that it's cystic duct, and open it up.
Yeah. For me, I have issues sometimes with the valves in the cystic duct, and I find that the solution to that is to dissect down the cystic duct and straighten it out. Do you do that ever, or do you find that to be an issue if your wires are catching or anything?
No, we haven't found that. I mean, the other thing that I'll do is I don't usually use a Maryland, but I'll have them open one, and I actually go right inside the cystic duct and stretch it at the valve and kind of open that valve up area. That sometimes is helpful. We haven't had that big a deal with it. But usually that wire will go if you fiddle with it enough.
Sure. What else does the person need to know if they're going to add this to their practice that we haven't touched on?
Well, I mean, think if they're a rural surgeon, they're doing flexible endoscopy, and so the cholecystoscope's no different than the same. It's got the wheels on it, and you have to inflate. It's more like cystoscopy because you have to put water in there to see. It's not air. But no, I think there's a lot of good videos out there. You have to know the anatomy, obviously. But I think if you're doing cholangiograms, particularly if you do them like you do, where you're opening the cystic duct and you have to put a catheter in that, it's not a far jump to put a guide wire down there and use the biliary catheter. It's certainly worth a try. You're not going to hurt anybody doing that.
Right. Yeah, I think, your bronchoscope and cystoscope, like you said, it's the same function. You're basically turning your wrist, your thumb's going up and down, and then you have the insufflation. So I use a 3-liter irrigation with pressure bag. And then the other thing is with your cholecystoscope, you're going to have a second camera sitting there. So maybe I can throw up some pictures of myself doing this with a nice setup and scoping a stone right in the duct, because I've got some good pictures just of like what the setup actually looks like. So we'll put that up here for the video. But basically, you're going to have a little second setup that you have to have. Your team has to be comfortable managing and hooking up for you, and AV get the cords and everything. But it's once they've done it a time or two. The nice thing about the rural hospital is it's a small team, so you don't have to teach 100 different people how to do this. You just have to teach your handful of techs that you have, and then everybody knows how to do it. That continuity is one of the best parts of my practice, actually.
And I think that just to mention that if there's a whole bunch of stuff above the cystic duct junction up in the proximal common duct, then you're probably not. If there's one little stone, you can put the patient in head up position, see if gravity pulls it down. You can suction on the cholangiogram catheter and see if you can draw it down into the distal duct. But you really can't go backwards very easily with the cholecystoscope and go fishing those out. It's mostly, and that's where most of these are, it's in the distal duct. But if that duct is completely filled, like a bunch of train cars lined up, that's not the one to start on.
Reminds me, 2 more questions. Glucagon.
I give it on everybody, 1 amp before we start.
Before you start every gallbladder case?
No, before we do the common duct exploration.
Okay.
Yeah.
And then you give it 3 minutes and try to push hard and see if it worked?
Yeah, I mean, I think you can give it while your cholangiogram catheter is in there, wait 3 minutes and push, and see if you get lucky and it flushes it out without doing the common duct exploration. But I think just when you get that balloon in there and you push, I think that the glucagon will help to get that going too.
Yeah. That's the thing. So I don't have super huge volumes, obviously small, your small place, but I have never had success just giving glucagon and trying to flush. So if I've had it successfully flush through without giving glucagon, just with my cholangiogram. But once I gave glucagon, I never actually had a success afterwards. So I'm not super, I still try it, but I don't have a lot of hope. One of these days, maybe it'll work. Last question was, how do you tell the difference between a bubble and a stone?
Well, we're very particular about who's setting the cholangiogram catheter up and the syringes. It drives us crazy when you do that. But bubbles act differently. They move around. If you suck back on the cholangiogram catheter, they elongate sometimes, or they go away, or you can flush with saline, clear the duct, and do another cholangiogram if you're worried that it's a bubble.
Yeah, bubble maintenance is the most important thing there.
Yeah.
Great. Well, thank you. This was a wonderful How I Do It. If you enjoyed today's episode, stay tuned for the second part of this conversation with Dr. Sarap in the next episode, where we discuss financial tips, but also meaning, purpose, and the Japanese concept of ikigai, some really intense rural surgery stories, as well as some resources for the busy rural surgeon, especially one who wants to publish. Dr. Sarap is an expert at that. See you next week for part 2.